Please.
Sure.
Thank you all for joining us to this webinar arranged by Planetary Health Academia. So about Planetary Health Academia, we are a completely volunteer organization, and we are the physicians of Bangladesh origin living abroad, but we collaborate with all the professors and young physicians in Bangladesh. Learn from our senior professors in Bangladesh who are our teachers. This is a completely volunteer organization. We have two sponsors, Incepta Pharmaceuticals and United Hospital, but we use the sponsorship entirely for logistics purposes. So today we are honored to have Professor Fazliluddin Malik, Professor and Chief Consultant, National Heart Foundation. Everybody knows Professor Malik. We will also have Professor Mir Jamal, and he's the Director of NICVD. We have Dr. Tamzid Ahmed, a Senior Consultant and Interventional Cardiologist at Evercare. We have Professor Azam, Interventional Cardiologist from NICVD. I'm Nasser Khan. I'm also an interventional cardiologist. I am at Methodist Medical Center, Dallas right now. So our speaker today is Mashrafi. So Mashrafi will talk about a topic that we see a lot, but we do not discuss a lot. There is not a lot of studies, but so it's a tough topic to discuss, but we chose this one because we all want to learn about this. So Mashrafi graduated from Dhaka Medical College, and he trained in cardiology at University of and he's now a clinical assistant professor at University of Massachusetts in Bay State. So I'd like to invite Mashrafi to start his lecture, please.
Thank you, Nasser Bhai. Thanks for your kind introduction, and thank you all my respected panelists for your time and effort to join and teach all of us. The topic that we chose today is the SCAD, the spontaneous coronary artery dissection. And as we were speaking about it, we don't have a lot of data cases, but we frequently see these things, and we always hobble on how we are going to manage these things. There are many unanswered part or sections in this topic, and that's why I particularly brought it up, considering there are so many senior interventional cardiologists are here today. We would like to share our experiences and enrich our knowledge by that. So we will start with few cases. Let me put my slides on. Host a disabled participant screen sharing. I need to.
You can share now, sir. You can share
okay.
Now.
Thank you. Can everyone see it now?
Yes, you just have to blow it up. Yeah, good.
All right. So today's our topic is spontaneous coronary artery dissections. So we'll start with a couple of cases. These cases are a little bit dramatic. Dramatic cases here we see. So the first case is a young, middle-aged, 61-year-old female with not really much past medical history, doesn't take any medicine much at home, not a smoker, who presented initially in the emergency room. We got a call because someone came with a chest pain and a little bit of EKG changes. Not really very much significant EKG changes. And when we went to see her in the emergency room, her chest pain was partially resolved. So we said, all right, we're just gonna see how does she do. Positive is 1.1. So while we are in the emergency room, we saw she in fact developed again chest pain. And Then there are some dynamic EKG changes, now more STT changes in the anterior leads with inversions diffusely. And then within 5 minutes of that, she continued to have chest pain and more EKG changes. So this was around like 6 in the evening. So we thought that, okay, rather than coming in the middle of the night, let's just take her to the cath lab. So we took her to the cath lab and we took our first shot on this slide. So show this one, that if you come all the way down here, there is a caliber change in the right coronary artery in the middle, which looked like little suspicious to us. So when we saw that, so the first question is, should we give intracoronary nitroglycerin or any sort of vasodilators when we see this sort of little bit of caliber changes in the middle of the coronary arteries? Any suggestions or any thought process?
Maybe I just pitch in. I never say nitroglycerin to, almost never say nitroglycerin to intracoronary injection. Even in the face of hypotension, sometimes for sizing issues, you need to give nitroglycerin, but guide shot, first nitroglycerin. But here, looking at the angiographic picture, it looks like type 2 tubular type fibromuscular dysplasia or underlying maybe. Look at the way it is distal. So it looks like
Now, the reason I put that question in, because you see that we many times, particularly on the right side, we see the vasospasm, catheter-induced vasospasm, but that usually starts from at the very beginning of the blood vessels, usually not in the middle. But have we experienced some sort of vasospasm, particularly in the middle of the vessels, not proximally where the catheter is in touch with the vessel? Do we usually see these sort of scenarios, or it's usually not, right?
Nitroglycerin and see what happens. I mean, it could be.
Right.
Yeah.
But you should have a sense. What is little puzzling though, because we saw the dynamic EKG changes in the precordial leads, almost like Wallen's type. But the coronary, the angiographically, the distal RCA looks suspicious for SCAD.
Right. So in fact, we give nitroglycerin on this one. So because we, as you said, Hafiz Bhai, we saw the EKG changes more in the different territory as in the EKG, but here we are seeing here. So we give some nitroglycerin and took a couple of shots, but it's all there. Two-vessel coronary artery dissection involving both right coronary arteries as well as the LAD.
You play the whole, like let it run until the end. Yeah.
Mashrafi, how old was the patient? Any recent pregnancy or anything like that?
No, she's like a 50, 53, I mentioned.
Okay,
right?
okay, so she's
61, sorry, she's 61.
Okay, all right. So she's most likely post.
She's 61, all on and again came back and then came to the emergency room, and she was having some hemodynamic dynamic EKG changes time to time. That's what we brought her to the cath lab emergently and took those shots. So this is the first case, and then I'll show you another case. So this is a second case. This is a 51-year-old female who had a history of epilepsy, presented to the hospital with chest pain, and a very typical presentation of saying that I have an elephant sitting on my chest, what we read in our Davidson's for
Mashabi, sorry, what was the ventriculogram on that previous patient?
Antroceptal hypokinesis, apical hypokinesis on this patient. I really did not do a ventriculogram on this patient. Our EF was around like 45s on the echocardiogram. And I'll tell you what happened to her, because that's going to be something also we'd like to discuss about her. So this is the second patient, came to the emergency room, and we clearly see that there are inferior ST changes, some inferolateral, and reciprocal changes as well. So not for her. So she had some circumflex area, circumflex circulation. You can see the guy is hanging there. So she was once again, she was pain-free when we were doing this angiogram. And as we are going to talk about discard management, we performed we just proceed with a conservative management for her, and she was discharged home. And then on a treadmill and started developing chest pain. And she came back again to the emergency room from the cardiac rehab. And this time you see that EKG changes is a different territory. And it was, in fact, this time one of my colleagues, in fact, did the case. And patient VF arrested in the emergency room. She was intubated, shocked multiple times, and then came to the cath lab. As you can see, within 2 months, that first dissection in the
surprising how big the vessels are, and how narrow they looked when she had the scan the last time.
Right. So if we go back to her first time and see this, that her LAD at that time was quite good in size, and then this branch is completely gone. And this time, this circumflex in this scenario, she was in shock, cardiogenic shock. We called the surgeons in and we asked, okay, what we can do. But the surgeons really could not help much, because where they're going to plug in the lima, the whole LAD is dissected. They could not really have any options or opportunities to put lima somewhere. So she was not doing good. What my colleague did, in fact, just wired it. So wired it, IVUSed it, and IVUS where to start for stenting and where to end, because we do not have any end of this dissection, unfortunately. From very proximal LAD, the whole LAD was dissected. So it was just ballooned and left like that with a balloon pump at the end. And luckily she recovered. She recovered Her ejection fraction is now 30 to 35%, but she made it out of the hospital at the end. And regarding my first case that we saw, on the third day, she had one episode of chest pain in the evening, and then at night she went to restroom, arrested, and died. We could not bring her back. So these are the two extreme or dramatic cases that I just showed. You know, there are many SCAD cases which are not that extreme or dramatic, but these are the two extreme cases that I encountered in last few years. And
she died with the cardiac arrest. And what was
to see what exactly had happened? It looked like she had a more, again, inferior ST elevations at one point at telemetry. But, you know, she was out of bed. She was going to the bathroom. So there was a lot of junk on the telemetry recording. And then she VF'd in the bathroom. Okay.
It was a VF arrest.
It was a VF arrest in the bathroom. And, you know, definitely the OT team was called upon, and then they went there to help her, but they could not. Her to the lab or look into what exactly had happened, because she expired even before that. So spontaneous coronary artery dissections, we do not have a lot of guideline. There is a scientific statement from the American Heart Association, which was published 2 years back. So the students who are, or the young physicians who are here with us, I would encourage you guys to read these two articles. One is in the circulation. Another one was published, I think, last year or year before at New England Journal by Esther. The epicardial artery dissection associated with atherosclerosis or with atherosclerosis or trauma, but not iatrogenic. We see iatrogenic dissection, which is not a SCAD, definitely. And it's a rare event, 1 to 4% of overall acute coronary syndrome cases. But most common cause of pregnancy associated MI. Almost 43% of cases of MI in pregnancies are probably related with SCAD. Epidemiology-wise, usually the middle-aged females are 60%, and then circumflex and RCA. The multivessel SCAD is not usually the common one, but we have, as I showed you, there's a multivessel one we encountered and the patient did not came out good. Peripartum SCAD usually are more severe form. They tend to involve left main and multivessel. They come out with more decreased ejection fractions, and usually presentations are like STEMI rather than NSTEMI or other presentations. So mostly they're STEMI with severe we thought that it's probably a dissection and then propagation of dissection, but nowadays it's hypothesized that usually the beginning process is intramural hematoma. So there is a bleed in the vessel wall, and that eventually either channel through and form the SCAD or dissection of the vessel. Conditions, fibromuscular dysplasia is probably the most common one associated with SCAD, and pregnancy, particularly when multiple or advanced pregnancies or multiparity, we see more SCAD in them. Connective tissue disease with SCAD. Some people with migraine headache may have them. And things that precipitate in these particular groups are exercises, intense exercises or intense Valsalva. We hypothesize that in our first case, she went to the restroom. God knows whether she was having intense Valsalva at that time, and did it propagate any dissection that caused her VF arrest? Could be, but we could not confirm it. But those are the scenario where the dissection are more precipitated. The questions are female hypothesis, but not really established, just because the percentage of postmenopausal women who are in the SCAD registries are in fact more than 50%. So female who are advancing age, they tend to have more SCAD. And peripartum SCAD accounts for only 15% of all SCAD cases. So when the peripartum period, where we think about the hormonal surge, but we do not see that many SCAD in the peripartum. Play a role in pathogenesis of SCAD, but I think that's not the sole thing here. And definitely we have seen SCAD in the male, although less, but we have seen SCAD in male patients as well. STEMI is the predominant presentation. Then comes with NSTEMI. Cardiogenic shock or ventricular arrhythmias are not uncommon, but rare. It's usually less than 10%. So the type of SCAD, there are 3 types, type 1, 2, and type 3. The multiple channels or lumens in our angiogram, which is obviously the SCAD appearing, that is a type 1. Type 2 usually are long lesions, more than 20 millimeter, and they are divided into 2A and 2B. If the SCAD segments are in the middle of the vessel, did not go or doesn't go all the way up to the end of the vessel, that's a 2A, and then 2B is the one that goes all the way to the tip of the vessel. So our first case, the left or LAD was the 2B type SCAD in our first case. Type 3 is the most confusing one, because usually these are small lesions, less than 20 millimeter in length, and many a times they mimic atherosclerosis. So although there's no guideline, but if it is a type 3, how are we gonna really establish that diagnosis? Usually it's said that if someone who is young, who does not have any other or evidence of significant atherosclerosis elsewhere in the coronary system, and we are not expecting or suspecting coronary artery disease, maybe a type 3 SCAD, and that is the only time the imaging was recommended or suggested. I will not say recommendation, I would say suggested that we can use the IVUS or OCT imaging in those scenarios. Other than that, most of the time the OCT and IVUS are not really used or suggested, just because as we know, it may propagate the dissection more. And as we were talking about that nitroglycerin, for type 2, they recommend then give some intracoronary nitroglycerin to see if there is So management of acute myocardial infarction related to SCOT is mostly conservative, because the studies showed that if we perform PCI, the risk of complication and suboptimal outcomes are higher. So the PCI failure rate is from 36% to almost 72%. So almost 3/4 of the patient may have a bad outcome if we perform the PCI for them. Only if someone is artery dissection or hemodynamic instability, only in those sort of scenarios it may be okay to go ahead and do the PCI. Like our second case in her second presentation, she had that VF arrest. She was in shock, and there was not really much option for surgery at that point. We just ballooned it and put her on a balloon pump. We even did not put any stents because not sure where to start and where to end. So the target vessel revascularization and target vessels blood flow on subsequent angiography, people who are treated conservatively had the better outcome. So conservative management required less future target vessel revascularization and showed to have better flow or preserved flow in the long run. So many times we do the conservative management. The next question is, if just leaving that behind, are we going to continue blood thinner or the heparin or Lovenox? What is the usual or most commonly used anticoagulation in Bangladesh at this time? If kindly someone share their experience. I think in my practice, we predominantly use heparin. Any NSTEMI patients or unstable angina patients, we start them with the heparin and continue them until we take them to the lab, and usually and then do the PCI, and definitely during the PCI predominantly use heparin. I have used bivalirudin time to time, but current the culture or the trend in our lab is mostly using heparin, checking SCT, making sure that we are therapeutically anticoagulated. What is the practice pattern in Bangladesh at this time? Is it
Dr. Asha Kader in chat box said we use enoxaparin. Is that the standard?
Yeah.
No,
I think
I might add, but in the labs we use
repeated in other issues. So that is a common practice in general, whether it's atrial fibrillation or non-STMI. But in lab, we give, of course, bolus unfractionated heparin during the procedure. Fondaparinux sometimes we use, as you said, bivalirudin is out of match nowadays because of more thrombotic episodes, so we don't use anymore. Mostly is enoxaparin. Thank you.
Is it the same practice in National Heart Foundation or NICVD?
In National Heart Foundation, for acute coronary syndrome, we would use low molecular weight heparin, and as Aisha has said, but in Heart Foundation, we do use a lot of bivalirudin, especially in patients who are high bleeding risk, like maybe a CKD patient, and we would have to do a very complex PCI, and we have to use the femoral route. Then we use bivalirudin. In our hospital, we use quite a bit of bivalirudin even now.
Thank you.
Thank you. In National, I am Professor Mir Jamal. In National Institute of Cardiovascular Diseases, we routinely use low molecular weight heparin, and in the cath lab, conventional heparin we use. And bivalirudin experience. Besides this, particularly, I am radialist, so I do not think there is any more superiority of this bivalirudin in case of radial intervention, and that is why I do not usually use bivalirudin in my lab.
Thank you so much.
Anyone using low molecular weight heparin IV during the procedure?
Initially we use, but nowadays we do not use.
I never used, in fact, low molecular weight heparin during the
first marketed low molecular weight heparin in Bangladesh. That was really hyped, and a lot of us did use it. It's pretty effective, and you don't have to really check the ACTs or anything, which makes it very convenient also. Not bad. I mean, but I don't use it nowadays.
I think during procedures, the US has probably reverted back to heparin. I mean, a few years ago, we were using a lot of bivalirudin and GP2B3A with heparin, but now I think it's just plain old heparin. That's becoming, during procedure I'm talking about, that's becoming the common practice. And also for non-STEMIs too.
Already more, but now 50-50 in our lab, but I'm more heparin, and I'm using and actually I learned heparin use after going to Bangladesh. I said, let's reduce the cost, but now bivalirudin has come down. So when bivalirudin was expensive, I actually switched to heparin at that time to reduce cost of the lab. And I learned this from Bangladesh, that they're using high dose heparin and fine. And also we know heat PCI and all that, heparin is good. And particularly we have powerful antiplatelet oral agents now.
Because when I was in Boston during my interventional training, we used a lot of bival at that time. But in Bay State, where I'm practicing now, or where I got my general training, it's predominantly now the heparin which we use. So I think it's also a little bit of hospital and the lab culture that dictates a little bit, but it takes a little longer probably. We give heparin and then wait for a few minutes to get the ACT checked and then start the procedure. So sometimes in STEMI cases, so getting back to this questions, that should we continue the anticoagulations if we are not performing PCI for the SCAD? So as we go back to the pathophysiology, it starts with a bleeding intramural hematoma, and that's why it is suggested that we should not use anticoagulation. If you're not, even after not doing PCI, it's okay not to give them anticoagulation and keep them in the hospital with monitoring bed, so we know what exactly is happening, hemodynamics, time to time EKG, or if telemonitor is available. Here we know that this is a SCAD and we are doing conservative management. So if someone is already on anticoagulation, like someone with atrial fibrillation, and they are on Coumadin or Xarelto, apixaban, what would be our decision? Should we continue it or should we hold it? I came across this problem and I do not know what to do because there is no clear data. So for someone who had a history of DVT 6 months back, I stopped it. I did not give the Coumadin to these patients or any other. Continued it And I really do not know whether I did the right thing or wrong thing. If there is any experience or any other thought from our learned panelists, please share. Nasser bhai, any thoughts that you think we should hold anticoagulation for any other purposes at that initial period or no?
I mean, if there is no contraindication, I don't see any reason why we should hold that. I mean, I would so.
Really, not much data.
Okay.
Really, not much data. I looked into that, and there is not really any series to say if someone in atrial fibrillation is already on anticoagulation and they came with a SCOD, what would be our thought process for the anticoagulation? There's no data on that. I really do not know. It's just a matter of experience that I think that I go by.
There was a publication, I think last year, on a SCAD that they reviewed. I think they reviewed like hospital recorded SCAD, and they found, I think, in a large and then found 0.05%. And it is a pretty good sort of summary of how people behave, operators, how many interventions, and what medications they used. So there was no mention about instituting anticoagulation. We all kind of agreed not to start anticoagulation, but there was no reservation for holding anticoagulation. But of course, you readdress the issue. What was the indication in the first place? But if there is a genuine indication, then you continue. But yes, we all kind of agreed to continue.
The next question that I put here is, what about dual antiplatelet regimen? So you want to continue DAPT for this group of patients? And if you want to continue, how long would be your suggestion?
So, I mean, again, I don't know if we have any data, but in my practice, I continue it like, if I'm treating a non-STEMI with the medication, so that would be at least a year, and of the so aspirin indefinitely and Plavix or clopidogrel or Brilinta for a year. So that's what I would do.
The problem is that should use the DAPT, but there is a controversy on this, and the argument on the acute coronary syndrome and for dual antiplatelet is really for the type 1 MI. This is not type 1 MI.
Right.
And therefore, some would go against it. I don't think there is any consensus, but typically, if you look at the natural history of SCAD, those who have this type 1, or for that matter, there is another type, this is the EPSAW classifications reported a few years ago, and then an additional is the 4, where there is complete occlusion distally, very typical. And generally, if it is usually 2 to 3 months, they heal. So my request will be that even if you are thinking about that, I would not continue longer duration DAPT. I would.
So I guess, Hafizbhai, you're right, because Aisha actually mentioned about, Aisha, can you shed some light on that? She mentioned about a registry data that showed that people on DAPT did worse.
Right. So there is in fact a lot of controversy. As you said, this is not a plaque rupture things, and the thing starts with bleeding. So many people have really shown their concerns that considering dual antiplatelet may in fact worsen it. So it's really wonderful.
Thanks, Mashudi. Not so much my thoughts as what was published, I think, at the somewhere maybe a couple of months back, which was a not very large registry. I think there were about 300 SCAD patients, and those who were on DAPT had worse MACE at 1 year than those on single antiplatelet therapy. So, I mean, it's not randomized data, so to speak. It's just a registry. But, I mean, I think in this event of scarcity of data, that's something to go by. So it's actually interesting to know what others might do with SCAD in ACS without a stent.
Panelists from Bangladesh, Professor Malik or Professor Mir Jamal or Professor Azam, if they would like to know their thoughts on this.
Yeah, please.
Asir,
Azam, please. Yes, please, please.
Actually, regarding DAPT, first I come to DAPT. What is the reason to continue longer duration DAPT? We have to evaluate first. Either the patient required DAPT for 3 months, 6 months, 1 year or more, then we should be individualize the patient. As because you much significant, we should wait. Mostly we can treat it by conservative. So in that particular situations, this should not be considered as a high bleeding patient. So how we should continue lower duration or longer duration. If we consider the higher thrombotic risk, then we should consider longer duration. Usually there is a American College of Cardiology recommendation 2018 probably. They give a summary statement. Preferably single antiplatelet echospin is enough. You can continue at least 1 year. If you think there is a very high risk thrombotic event, then you can consider DAPT. According to thrombotic risk. This is my practice, I think. And regarding anticoagulant, usually almost everybody nicely placed in our country. We mostly used heparin, and in the thinking of the low molecular weight heparin, we commonly used enoxaparin, but NSCVT right now we are using fondaparinux from the COVID era. This is our institutional practice. Thank you very much.
Ahmed, how in your institute would go if there is a SCAD patient?
Actually, we have very little experience with SCAD, to be honest with you. We had one young lady, pregnant lady, we had a few months back with ST elevation and TMI, and we've subsequently showed a long dissection from aorta to LAD to left main. So we actually did stented that patient because patient was ongoing chest pain, and we did stent from left LAD to left main altogether, the whole left. Conservatively, medically it should be. But in that particular scenario, we had to stent the patient. Elevation, ongoing chest pain with left main dissection, as mentioned in our presentation as well. So better cover the left main. If it's left main, you go for stenting as well. So that patient we actually stented from LAD to left main. And obviously, we know it's a pregnant lady. This is the highest chance of getting pregnant on peripartum period has the highest chance of getting SCAD. And particularly female population. We don't know why. Maybe, as you said, neurohormonal reason, hormone related with estrogen and others can cause more of a dissection than male population. Mashrafi?
So again, sorry. Yeah, so it's Yeah, predominantly is female. I don't, in top of my head, I don't remember what the ratio could be, but it's predominantly.
Remember, it's like lupus, 9-1. Some reports 7-1.
Lupus.
9-1 or 7-1.
Yes, that's right.
Now, Dr. Tamzid Ahmed, when you stented it, did you consider any time to think about?
Actually, we use, to be honest with you, only had a DS on our shelf. So we all the stents we use actually DS.
Okay. And the reason I asked about this question.
But it's not our usual practice to have the patient like this. And as a result, we treated the patient that time, a few years back, with a stenting from distal lady to left main as well.
Ashrafi, actually in our country right now, we don't have any VM assistant, especially in my city. Number one. Number two, it depends, and
So to be honest with you, no, we all are stents on DS now. We don't keep any DMS anymore.
Right.
In a shelf.
So
because the price is down less than before, even DS is not much nowadays. So I believe that's still it's better to use DS.
Yeah, we also removed all BMS, but I'm actually happy that Bangladesh removed BMS well before we did in our lab. I don't use BMS.
That's
no. I asked this thing particularly.
Ashrafi, one interesting thing I have explained. Two female, no need of any stenting, but all three male is required stenting.
Really? Wow.
Very unfortunate.
Azom, Shono, Scadolo, bouncer or Yorker, you leave it masterly, you leave it alone. If you can. If it is going in the middle stump, you'll have to play it.
Okay, I got his point, but literature shows there is a female predominance.
Yeah, no question.
This is a controversy whether we should continue clopidogrel or any DAP, how long. I think it's still up in the air, and it's how much we are comfortable. My practice, we usually try to, if the problem is extensive, maybe a month. We give a month or 3 months max of dual antiplatelet, and then only aspirin. Try to take out that second antiplatelet as quickly as possible. And regarding that second antiplatelet, I particularly choose Plavix, the clopidogrel, rather than ticagrelor or prasugrel. Just anti-anginals, beta blockers. Beta blockers are probably one of the cornerstone in the management of SCOT patients in the ongoing or in future after their initial event. It is the most important medication probably so far came out in the studies with prevention of recurrence. So Jacqueline Shaw, she's one of the pioneer in SCAD. She's I believe in British Columbia in Vancouver. So her registry data showed that people who are on beta blocker and their blood pressures are better controlled. If they have LV systolic dysfunctions according to the national guideline, but we have to be conservative about those used at the time of reproductive age, considering the teratogenicity, particularly as this often we see in the peripartum period. What about the statin? This was a debate at one point in our hospital. whether to give statin to these patients as we do in any SES, in STEMI or NSTEMI patients. We put them on high intensity atorvastatin, 80 milligram, usually try to give them if they're extreme. Had increased experience of recurrence of SCAD. Small study, 87 patients in that, and then 17% had a recurrence of SCAD in 47 months of trial. So that was one thing that produced this controversy, whether we should put these patients on statin or not. So we had once even thought about not putting patient on statins if they had a SCAD event. Then there was a bigger set from Jacqueline Shaw's paper.
There are other indication, continue the statin or start statin. If they don't, then don't do statins. Right.
All right. So anti-anginals, and not really much role as state, but it's once again very little data. So I think it's on us to decide on whether the patient should be put on anti-anginal, because I have seen patients who had SCAD event and then after 6 months still have chest pain time to time. So I put them on anti-anginal, but not really any strict guideline on that. So as we see that the SCAD is a is one of the clinical events that around the pregnancy. How should we advise them for future pregnancies? So this is something that came up. So low-dose aspirin is safe, and there is no clear data or safety data on the clopidogrel. So avoid if there's no PCI. Labetalol is probably a preferred agent for beta blocker, as we know. Metoprolol and atenolol are associated with placental and fetal weights and bradycardia.
Why labetalol preferred?
Just because it's, for any hypertensive pregnancy-related hypertension, labetalol is a preferred agent.
You say in the pregnancy.
In the pregnancy, right. Yeah, it's for the pregnant. Lower placental weight and fetal weights. That's why labetalols are shown on those. And definitely, it's, as we have seen, that the more pregnancy, more chances or risks of SCAD. So it's probably okay to counsel our patients for future pregnancies. Like if the family is complete, avoid pregnancies because the chances goes high with higher potential risk. What about other than coronaries for any other values? So far, we know that the SCAD has very commonly associated with fibromuscular dysplasia. So it is now recommended that we do a vascular imaging from brain to pelvis for patients who are at higher risk of fibromuscular dysplasia and SCAD. So now I do that for my SCAD patients, that I do a vascular imaging, either a CT angio or an MRA from their brain to pelvis.
The strep bovis infection and colonoscopy, it's like a driving test. So similarly, when there's a SCAD and they ask for any other imaging, you know that they are asking for, intracranial and renovascular. So it's a very interesting board question.
Yeah, and in the vascular abnormality, the renal arteries are predominantly affected in the SCAD patients, and then subsequently the extracranial carotid arteries are predominantly affected. So these two vascular beds are genetic testing for fibromuscular dysplasia are not recommended for SCAD patients. Is there any study between CABG versus PCI? I'm not aware. BMS versus DES, I brought that up just because I wanted to know whether anyone choose BMS considering the dual antiplatelet duration, but I think we have that consensus that we don't use BMS. In fact, in our lab, we may have BMS, but I really have not used it for quite a long time.
And actually, studies have shown that, drug-eluting stents, the second risk and all, are much safer than a BMS.
Right.
So it's more sensible to use the drug-eluting stent.
Drug-eluting stents nowadays, right? And that's why we, even with the high bleeding risk patients nowadays, we still go with the DES with a short draft.
Interestingly, for this is another board question, that if you say that for argument's sake, you are giving BMS in this patient, will that shorten the duration of the DAP? The answer is no, because if you are taking it as an MI, then I'm saying in otherwise acute coronary syndrome, the duration should remain 1 year because it is ACS. So that's a tricky question in the board exam. And by the way, the PCI versus CABG, and if you look at the big registry that I mentioned, always a problem, because CABG, you may want to do it, and then the artery heals and the graft will close. So it is very important to remember that this is a race against time. So buy time, stabilize patient. PCI, and if you are there, you know how bad it can be. I remember from Mount Sinai days, they said, don't see don't save it if you are intervening, because it is going to get worse. So I don't know much of your case. If I did not know about the patient, I probably would have put a wire in the LAD because of the cardiogenic shock and VF. But that patient, luckily was in your lab, and you did not do masterly inactivity. Circumflex healed nicely. Why the balloon only? Because balloon is like going to Afghanistan and not come out good. If you are ballooning, that means you are making a mess. And they talk about longer stent, so that you cover proximal distal very well in case of a SCAD. But better to not stent. But if you do end up stenting, this stenting is a little different than otherwise, because you have to use longer stents.
Right. For the second case, I know there are a lot of discussions. LAD. So we are starting the dissection from proximal LAD to all the way down. And if we cannot keep the outflow, whether the stent will stay open or not, there is no option for cabbage because its whole LAD was dissected. There was no way there's no place for a touchdown to Lima. And whether we should put this patient on VA ECMO or just leave on Impala or balloon pump, all these things were in that lab on that day particularly. And I just feel bad that the colleagues who did that in the lab and really do not have a very clear-cut answer which way to go. But these are rare events that we encounter, and we do not have much insight on how best we can proceed with that. So this last question,
one thing, because everybody is here, one thing is very important as interventionalists to remember that once we balloon it only, then we are revving up the platelets huge. So at that point, just leaving on anticoagulation is not going to vessel closer, giving VF rest and died. Unfortunate, but that's probably my guess.
Right, but at the same time, if it is not a plaque rupture, it's just a dissection causing a vessel closure, is ballooning gonna adversely affect in this scenario, or is it gonna be same like a regular MI?
You're going to increase the dissection when you balloon, right? I mean, there's a tear, and there you are with your balloon, and you're inflating it. So you would expect the dissection to increase. So when you have a dissection, you have to be very, very gentle. That's why you don't take a wire, you don't give vigorous dye, you're very gentle. So what you're doing with a balloon, you're basically increasing your dissection. You're tearing up the vessel. And then you don't put a stent. I think you might end up in trouble.
I think most of the time when we are wearing it and ballooning it, we end up putting the stent. But particularly in this case, the dissection is so huge from top to the bottom of the vessel. And first of all, we were not sure whether we were going to even wear it. And the vessel is completely closed. The patient was having VF. So, all right, let's bite the bullet. Let's bite the bullet and wear it. So we wired it.
No, that is the point. What we learned from these cases, and you nicely showed, that when it is an Afghanistan and Tora Bora, the best thing is not to go there at all. So that's what I'm trying to say. Particularly in your second case, it was a gift from God that the circumflex had this problem. Circumflex healed nicely. And this is a spontaneous dissection. Because if the patient came in first time, not classic distal and not like atherosclerotic or not, and patient is shocked, all this. But my argument is that when there is a clue that this is SCAD and healed nicely, then there is all the reason not to do anything and give hemodynamic support.
I completely agree with Hafiz Bhai and Professor Malik here. I mean, I guess the most important learning point is if you see a SCAD, try just to leave it alone. I get so many, I think most of the calls I got from junior colleagues was about SCADs and what to do. We all feel tempted to stent it or do something when we see these lesions, but the most important thing is that you want to leave it alone. Impella in your lab, I mean, that's an amazing tool. I mean, we have pinched the left main with a TAVR and put an Impella, and even with the pinched left main, the patient became super stable. So if you have Impella, just use it. Put the patient in Impella, let the lesion heal, and just like the way it healed for the circumflex. That's what I would do.
Right. No, that's definitely the whole point.
I'm sure you would have done it, Mustafa. You would have done it.
No, so what happened here? She in fact got shocked 16 times while she's on the lab. So she was like going in and out of the fib, and we could not, even with a pump in, that. And there was a lot of discussions, as you can assume. Oh, this is how we're going to proceed, how we're going to keep her alive, all these sort of things. But anyway, one last question.
One thing, when we discuss, I think one thing we learned that we don't go back and criticize our colleagues. We actually learn from it so that we think what I would be doing when I see the next case. I never go back and criticize. I say that we learn. They use their judgment on that day, that's the way they did it. But was there any clue? And what I would be doing if I encountered this?
On this slide list that I put in because of my first patient. So as you remember, first patient came with 2 vessel SCAD, managed conservatively. We didn't do anything. She was in the hospital. On the 3rd day, she VF arrested and died. So is there any particular thought process for all our learned panelists that if someone comes to the hospital and you see SCAD, how long you consider to monitor them in the hospital? How frequently we see this sort of recurrences of SCAD? And
clinically stable, we would discharge them. I mean, you just can't keep them for months and hope and pray that the thing will heal, because it's going to take months to heal. So I suppose once the patient is pain-free, hemodynamically stable, has good pressure and everything is feeling fine, a few days maybe, right? It would differ from patient to patient. Like if it's a symptomatic spontaneous dissection, patient is now stable, blood pressure and otherwise, we would discharge, I think. I mean, that's the general idea, right?
I would agree definitely with Appa. That's practical. And then registry report in Jack was that the main reason for rehospitalization is angina. And then those back with angina, believe it or not. But the main worry is that in a cohort of patients when there is arrhythmia, like, in STEMI patients, we BP arrest, we revascularized, and then we say, okay, no need of ICD or anything. But in a SCAD patient, particularly I was thinking about, and we are patients here also with the sustained VT and then VF arrest, and then we are discharging and we did not revascularize. Should we put them ICD or, because now we are talking about, it's not like the primary VF we see with the MI, STEMI. This is different ballgame. So many of our EP guys are, and then probably they will heal and then no further problem, then life-vest DC, and you don't need ICD. On the other hand, as Mashrafi pointed out, there may be a recurrence, and that recurrence may be with another VF arrest. So how do you do this? And I don't know the answer, but my tendency is that we should buy them a box and protect them from arrhythmia, because that's the nasty thing. Angina, we can deal with this.
It's a very good point, Hafiz Bhai. I really did not thought about that ICD thing. Our first case, unfortunate event, we talked to a couple of people, Melissa Wood and MGH. So some of them suggested that they do little longer than usual monitoring in the hospital. Some, like I think in Mayo Clinic, they try to keep them in the hospital for 5 days, because I think some of their case cohorts showed that the recurrence, if they recur early, they recur in the first week or first 5 days. That's why they keep for 5 days, but there is no really clear-cut data to say. And we always do that. Okay, patient is hemodynamically stable for 2-3 days. anyone any advice or experience. So that was the main thing. And the last question is probably is more we have to answer these things here in this country, because there are many people or many female who participate in competitive sports, because this is something we see in younger female. So a lot of competitive sports and exercise things that we have to answer to our patients. So definitely we tell them not to participate with vigorous exercise or resistance training. Particularly female patients, younger patients in their age of pregnancy, this SCAD is a little curse to them. They have to refrain for many of their activities and have to be very cautious about their future pregnancies. So back to our case. In fact, I talked about all those outcome of those cases. My first case did not make it out of the hospital. She died. The second case, she had 2 events. First event, she recovered completely within 2 months, and then she came back and had a going to the fibromuscular dysplasia clinic for further evaluation. Her ejection fraction is like 25 to 30 probably at this time, but she's alive. She's doing good. So that's from my side today for this SCAD. It's unusual cases, but thanks for all the learned panelists for their experiences. I learned a lot from all of you today.
Thank you, Mashrafi. That was an excellent lecture on quite a tough. I think Aisha asked a question about cutting balloon, use of cutting balloon to milk out the hematoma in intramural hemorrhage. Is there any role of that? Anybody want to take that?
Yeah, I have seen case reports on the cutting balloon. I don't know. I am not a great fan of using cutting balloon in that situation. If I ever plan for a stent, and we have done actually a couple, but I usually go with the longer balloon. Here's the tail, then I just back off. And I don't even do the balloon injection, as Papa mentioned. And then use longer stents. But some people have said that you can try the cutting balloon. I do not have any experience.
Yeah, I don't have either, and I probably wouldn't use that because just like we discussed in the past, I wouldn't want to make that area more angry, with the cutting balloon and things like that. It's gonna make it more intramural thrombus prone. That would be my thought. Like I don't want to make the endothelium more injured and angry. I'd like remarks before I go to the other panelists, please.
Well, thank you. This was such an interesting session, and I really enjoyed myself, learned such a lot, and that was a great presentation. Mashrafi, congratulations. Very nice meeting you. Thank you for inviting me over, Nasser. Really had a ball. I mean, I really learned a lot. So thank you. It's way past my bedtime. So I think I'll say goodbye to you, and you're wrapping up, which is great. And inshallah, hope to be here again for another interesting session. So thank you for inviting me, and I'll say Khuda Hafiz.
Thank you so much. Dr. Tamzid Ahmed. Tamzid Bhai, any concluding
Thank you,
remarks?
Dr. Nasser and Dr. Mashrafi. Actually, we learned a lot of things today, to be honest with you. So many important aspects, how to manage SCADs. Nothing much to add because I've already said many things. And I must conclude that this is an excellent presentation, and we should keep it up with newer things. You can combine with American and Bangladeshi experience together from your side, from our side, and we can learn from you a lot. Thank you very much.
Thank you, Mama. Thanks for joining.
That was the whole idea. Yeah, thank you so much.
Mastery presentation very wonderful. Number one, take home message from my side. First line therapy in SCAD is conservative. This is first line. Second line can be considered revascularization in the form of PCI. Of if indicated cases, we can go for CBG as you think. This is my second line option. And second line, it is A option, and second line B option. I heard, but I never practiced cutting business practice. It can be, but I don't know. I don't have any experience, so I never practiced it. Third things, we should be go to the literature and connected by each other people so that we can learn a lot, and we can learn very, very small manner, and we can think locally, but we can think globally, we can act locally. So hope for the best. Hope to see you next time with other interesting topics. Nasser, I think you can design very interesting topics so that we can learn in online session very small duration or very shortly, right? Thank you very much.
Thank you.
I joined a little late, but I learned a great deal from what I could see. So thank you so much for arranging it, and thanks, Masha, and also the panel for the great discussion. Thank you.
Masha. Hafiz bhai.
Onek raat, I'm close to them. Thank you.
Thank you so much.
Excellent presentation. Excellent.
Okay, thank you everybody for joining. Thank you. We'll meet again. Thank you. Assalamu alaikum.
Inshallah.
Thank you, everyone. Assalamu alaikum.